Hello and welcome. My name is Alex Flood. I'm a radiographer and X-ray technician program instructor here in the state of California. And this is another one of my review videos in which we discuss some of the topics that X-ray technicians should be familiar with. And I hope this is useful for people who are doing things like going through a program right now or studying for state or national testing. And in this section, we're going to be talking about radiation biology and the cellular effects of radiation. So thank you for joining me, and hang in there for the next roughly 20 minutes. Here, the first concept to get out of the way is linear energy transfer, or LET. Linear energy transfer, or LET, simply measures the amount of energy deposited in tissue per unit path length of the radiation's travel. So the way you should think about it is radiation is simply kinetic energy, either within massless particles or within massive particles, and that kinetic energy is deposited into matter that it comes in contact with. So biologic organisms made of matter, radiation deposits its kinetic energy into the matter, and we're measuring over how long of a distance the radiation deposits that energy. So two different types of radiation, like alpha radiation versus X radiation, will deposit their, if they came in with equivalent energies, would deposit their energies over much different lengths, much different path lengths. So, whereas things like the rad, or more frequently, more commonly used today, the gray, measure energy deposited per gram of tissue. So that's energy deposited into energy per mass. This is measuring energy deposited per millimeter of length traveled through that tissue, or more accurately for our purpose of measurement, the micrometer, as radiation penetrates into the body. So things to think about: a high linear energy transfer means the energy deposited into the tissue is more concentrated and will thereby cause more harm. So we can use the LET number to take and give us an idea about how harmful a radiation is, a certain type of radiation is, when compared to another type of radiation. Although any unit of energy and any unit of distance could be used, for our purposes, we're going to be using kilovolts per micron, so thousands of volts per millionths of a meter, kV per micrometer. So the example given, so that we can put a graphic to this, is to take and look at two incident particles on the skin and two different types of radiation. You have on the left 80 kilovolt and 80 kilovolt X-ray photon, and on the right an 80 kilovolt alpha particle. Alpha particles have an atomic mass of 4. They're about 8,000 times more massive than an electron, and they carry a charge of +2, being that they're basically a helium nucleus, 2 protons and 2 neutrons. Whereas the X-ray has no charge, no mass, and is just a wave in the electromagnetic field. But assuming both of these have the same initial energy, we can see just from the diagram that's given to us that they deposit that energy over much different distances, giving them different LET numbers. So on the left, an 80 kilovolt X-ray photon and its subsequent scatter photons travel a total distance of 24 microns. So you take and add up the distance traveled between the incident X-ray, 6 micrometers, the scattered initial photon, 8 micrometers, and the second scattering event, creating a lower wavelength photon, longer wavelength photon traveling at 10 micrometers. So a total distance of 24 micrometers. So you can say that 80 kilovolts of potential energy was deposited over 24 micrometers of distance. 80 divided by 24 is 3.3, so it's 3.3 kV per micrometer. That's our LET number for the X-ray photon. The equivalent energy alpha particle has no scatter events in this case, and deposits all of its energy within 3 micrometers of traveling through the body. One reason why we can't take, take and use alpha particles for diagnostic radiography because they don't travel very far through the body. They dump all of their energy very, very quickly. So it gets 80 kilovolts of energy deposited over only 3 micrometers of unit path length, and that gives you 80 divided by 3, a value of 26.7 kV per micrometer. So we can say that using this LET measurement, alpha radiation is more biologically effective because it deposits its energy into a much more concentrated area, whereas the X-ray photon spreads it out over a larger area. The LET values for typical types of radiation are given here on this graph. So on the left, the type of radiation. On the right, the LET given in units of keV per micron. That's the same thing, so think thousands of electron volts per micron. Diagnostic X-rays have a value of about 10 mega electron volt protons. That's protons, a single proton with a total energy of 10 million electron volts, a value of 4. A alpha particle with a value of 5 million mega electron volts, a LET of 100, and particles that are created in particle accelerators like heavy recoiled nuclei can have LETs of 1,000. So we can say safely from this graph, the most harmful type of radiation given to us on screen here are the heavy recoil nuclei because their LET number is the highest. So when compared to other options for ionizing radiation, diagnostic X-rays are actually fairly low on the spectrum of things that can cause harm. The more penetrating the radiation, the lower the LET. Our radiation that we use, diagnostic X-rays, very penetrating, so they have a relatively low LET. The thing to remember for your state board exams, X-rays are low LET. That's a phrase to take with you. X-rays are low LET. The next unit to talk about, the unit of measure to talk about, is the relative biologic effectiveness. All this does is take the effectiveness of a certain type of radiation at causing a specific effector disease. Basically, we're taking X-rays, okay, and comparing it to other types of radiation. So we're comparing X-rays to other types of radiation. That's what it is. So it's RBE is equivalent to a dose of 200 kilovolt X-rays required for some effect, compared to, or divided by the dose required for some other type of radiation. So let's take a look. The example given is what is the RBE, relative biologic effectiveness, for alpha radiation in killing 50% of epithelial cells. Those are the lining cells of our body. So based on empirical data experiment, it shows that it takes 2 grays of alpha radiation to kill 50% of those epithelial cells. But when given an equivalent, when given 250 kilovolt X-rays, it would take 6 grays to kill them. So the number in grays for X-rays to cause that harm are put in the numerator. The number in grays for the other type of radiation, in this case alpha, to cause harm, are given in the denominator. So 6 divided by 2 is 3. The way to interpret that is that you can safely now say, based on the math you just did, that alpha radiation is 3 times more effective at causing that specific damage than X-rays are. Said in another way, alpha radiation is 3 times more effective at, in this case, at killing 50% of the epithelial cells in this study. Typical RBEs for radiations that we can compare to. Diagnostic X-rays have a value of 1. That's comparing X-rays to X-rays, and so that's a 1-to-1 relationship. 10 mega electron volt protons, a value of 5. 5 mega electron volt alpha particles, a value of 20. And heavy recoil nuclei, a value of 30. So using the RBE, the 5 MeV alpha particles are 20 times more harmful than X-rays at causing any one specific type of harm. Next up is dose rate. We'll use dose rate to get an idea get an idea for the fact that, radiation is always administered over some unit of time. So we always have to consider time when we consider radiation doses, and the time over which a radiation dose is given actually has a big effect on this thing, the dose rate, how much radiation per unit of time. And the dose rate is directly related to the effects on the organism. Okay, so the example given. 2 patients both would receive 500 milligray, that's half a gray, of treatment in radiation therapy. The treatment time for each patient is different though. Patient A gets a 20-minute treatment, where patient B gets a 10-minute treatment. So, simple math will tell you the dose rate for patient A is 500 milligray over 20 minutes, 500 divided by 20, 25 milligray per minute. The dose rate for patient B got 500 milligrays over 10 minutes, so 500 divided by 10 is 50. The dose rate for patient B is 50 milligrays per minute. So who gets more radiation over any unit, over whatever unit of time you want to consider? Patient B gets twice as much radiation in any given amount of time that you're considering here, simply because their totally elapsed time for that dose was half of what it was for patient A. Even though the total dose is equal, patient B is more affected. Acute exposure is always more harmful than gradual exposure. Spreading a radiation dose out over time is always less harmful than putting that same equivalent radiation dose into a much shorter time. So when you're asking yourself, what's best for my patients during an exposure, it's going to be the dose that has the longest exposure time. If you're asking yourself, how do I minimize repeat exposures? Well, that's a different answer. You want to minimize exposure time. But from the standpoint of radiation safety and patient safety, the longer exposure times are the ones that are better for our patients. Using that idea of dose rate and that a longer dose rate is better, there's 2 concepts to put in here. We have protraction and fractionation. Protraction of dose is extending the delivery of a dose over a longer time. Protraction would reduce the dose rate. So whatever a given dose is, it's given over a longer period of time. Protraction reduces the effectiveness of the dose. And the example given, 2 patients both receive an AP L-spine dose using the same total of 20 mass. In patient A, the exposure was 0.05 seconds. In patient B, the exposure was 0.1 seconds. Who's more affected? So you just do the math. The dose rate for patient A is 20 mass divided by 0.05 seconds, and the patient A got a dose rate of 400 milliamps, whereas over that 0.05 seconds, and whereas patient B receives half that, so 20 divided by 0.1, 200 mA. Protracting the dose cut patient B's overall dose in half. The total dose is equal, but patient A is more affected because patient A got that same dose squished into a shorter time. In radiation therapy, which is where this is really more commonly used, large doses of radiation are used to destroy things like a cancerous tumor. To protect the patient, doses are protracted or fractionated, but this reduces the overall effectiveness in treating whatever the thing is we're trying to treat, the tumor, for example. So therefore, because longer times are better for the patient but are also less effective, you have to have a higher total dose calculated to destroy the tumor and still keep the organism, the person, alive. Lastly, is very similar to protraction, just a chunked up version of it. It's called fractionation. Fractionation is breaking the total delivered dose into several separated or discrete portions, allowing recovery periods between exposures. Fractionation is how we think about radiation therapy, allowing time periods between doses to allow the patient and we don't want to allow it, but it's going to happen, the patient to recover and the cancer will recover as well. We're hoping based on the theory that the patient's tissue recovers quicker than the cancer does. Fractionation, just like protraction, reduces the effectiveness of the radiation due to the extended delivery time, which is effectively protracting the dose and separating the dose into discrete treatments. Therefore, the total dose, as before with fractionation, or with protraction rather, must be calculated higher to compensate for the less effect over the longer time. An example given is a dose of 4,000 milligray, 4 gray, delivered in one dose would kill a cancerous mass, but would also kill a patient. For the record, for if you don't know, about one gray to the entire body is enough to kill a person. People can die with more than 1 gray. 6 to 7 gray to the whole body is guaranteed death for people, and most people would likely die with a dose of around 4 gray. But fractionated into 10 doses, and it wouldn't kill a person. What would kill the cancer? Because it got fractionated, though, and it's less effective in this case now, you have to increase the dose. So calculated out, they would have increased the dose to 6,000 milligray or 6 gray, allowing the patient to survive and the cancer to be destroyed. The theory goes like this. Using this graph, on the x-axis, the horizontal axis showing doses 1, 2, and 3, the vertical axis showing the number of cells left alive, using the shown in the on the solid line you have the cancer cells, shown on the dotted line you have the patient's normal cells, and you can see after dose 1 cancer cells and normal cells are low, but normal cells are higher in their percentage, and they both regrow. By the time you get to dose 2, the normal cells have regained to nearly 100%, and the cancer cells have decreased significantly. Dose 2 happens, both types are damaged. The cancer cells do not recover as quickly as the normal cells, and then you do another dose. The cancer cells decrease so much that they're not on the map anymore, so they're all gone, and the normal cells are not all gone, and they can regenerate. So the survival curve shows how normal cells recover more quickly than cancer cells from each radiation treatment, allowing the tumor to be destroyed and the individual to recover, ideally cancer-free. Okay, that completes my section on these units that we use to measure radiation dose and these concepts of extending doses over long periods of time. Hopefully this was helpful. Please check back for more in the near future.